All right, chapter 14, mental health disorders. This kind of complements a little bit what we were learning about in neuro, since they both originate in the brain. These are the different topics that we'll be covering today. I have them laid out in such a way that the ones that underline are like the type of disorder, and the bullets underneath fall under that category. So like autism, for example, is a type of pervasive developmental disorder. ADHD, ODD are not under pervasive development disorder. They're their own category. They don't fall under a category, and so forth. So if they're directly underneath the underlying one, it falls under that category. All right, so our first one is going to be talking about autism. Autism is a pervasive developmental disorder, which basically just means that it's a lifelong thing. It's pervasive. It doesn't go away. There's no cure. It's a genetic thing, so it's not something that can be really treated to improve. It's just kind of managing symptoms. Main symptoms with autism include things like social impairment, so having a hard time making friends, understanding body language, just kind of like social awkwardness. And there's different scales of autism. There's a range from very mild impairment all the way to severe. Typically, men have worse symptoms than women do for some reason with autism. Cognitive impairment is another one. So not just social impairment, but cognitive as well. So their IQs are going to be slightly lower, have a hard time learning, various learning disabilities, some language deficits as well, and this is also on a spectrum. So some autistic patients have speech, some don't have any speech at all. Some can say just a few words, some can just make sounds. Repetitive motions, so they call this stimming, which is short for like self-stimulating. So a lot of times you'll see autistic patients like flapping their hands, or even sometimes hitting themselves, which is a self-harming behavior. It's just, it's not really understood why they do that, but it's just kind of self-stimulation. It gives them some kind of positive reinforcement to do that. And then also aversion to physical contact. So they tend to not like cuddling. This is something that the parents tend to notice in their children when they're young. Like they don't seem to want to be cuddled. They don't seem to want to be snuggled very much. Etiology, no one really knows why exactly this is caused. There could be several different causes that could go into autism. For diagnostic, it's really just a observation of the behavior. There's not like a specific lab test or imaging that you can do. It's not like their brains are going to look different on an X-ray or CT. There's no blood test that can say, yes, you have autism. It's just looking at the behavior. And then so most children will develop symptoms and kind of show signs of it by the age of 4. So usually parents bring their kids in because they're concerned, like, oh, my child isn't seeming to engage with other children normally, or they're having a hard time in school, or like I said, they don't have that loving affection with their parents.
Sorry, ladies.
And so they'll bring them in to be screened. They have special autistic screening that can be done. For treatment, like I said, there's not really anything you can really do to cure it. So there's some medications that can help with symptoms. So some autistic patients, when they're higher up on the spectrum, they have more violent outbursts or like very irritable behavior. Sometimes can throw like tantrums, lots of mood swings. So if it's really bad, they can give them risperidone. Risperidone is a mood stabilizing psych med to kind of just calm their behaviors a little bit to make it more manageable. All right, ADHD. You probably all have heard of this. ADHD with this problem is kind of twofold. It's problems with inattention and impulsivity. So having a very hard time sustaining concentration, whether it be in school or a project at home. You just find your attention wandering or like losing motivation to complete tasks. A lot of the times they avoid activities that require sustained attention. And this can cause problems at home, school, work, social interactions. Especially with children, they have an inability to sit quietly, so this makes it difficult in classroom settings, especially Little boys tend to be diagnosed with this more frequently just because they tend to have a more difficult time sitting still in class. Being impatient, impulsivity, and hyperactivity. Again, most of these etiologies with psych is going to be uncertain because there's not like a one pinpoint answer like, oh, this is what caused it. It's kind of a multifaceted part environment, part, genetics, kind of a different mix of things. So there's not really any specific one thing that causes it. There tends to be like familial tendencies, like hereditary, typically passed down. Again, diagnosis is going to be just based on behavior. There's this book called the DSM-5. Anybody heard of the DSM-5? It's the psych kind of diagnostic manual. So if someone comes in to see a counselor or therapist, they can look up all the different criteria for how someone's like, okay, you have to have this many behaviors out of these things to be qualified to have a diagnosis of ADHD or a diagnosis of autism or many other personality disorders. Treatment, again, is just going to be based on treating the symptoms to make it more manageable. So for people with ADHD, CNS stimulants, so central nervous system stimulants, are going to be what's helping them, which is kind of counterintuitive because you'd think, oh, well, if they're hyperactive, they shouldn't have a stimulant. But what the stimulant is doing is it's stimulating their ability to focus and have attention, right? So it balances out the inattentive part of the ADHD, so it helps their mind to focus. So you've probably all heard of Ritalin and Adderall. Those are like the most common drugs used for ADHD. And there's lots of other drugs as well. They end in phetamine. So like amphetamine is for ADHD. Okay, then we have oppositional defiant disorder. This is just children that have a hard time following the rules and listening to their parents. So arguing with adults, having extreme defiance, refusing to comply with rules, having a very hard time with other children, blaming them, being aggressive, bullying even, tend to be very angry and resentful, acting out. So these kids with ODD tend to get into criminal behaviors like vandalism or theft. So they tend to have juvie records. What causes this is usually one of 4 different things that they found so far is that negative child temperament. So just for whatever reason, this child just like, even despite having a good environment, just like has this negative temperament about them. ADHD can contribute to this if it's really bad, untreated, and they're just not able to focus. They're just very hyper and constantly getting disciplined, so they just feel like they're just out of control. Negative parent temperament, so maybe it's not the child's fault, but the parent themselves just are very kind of negative and harsh and critical, and the child is acting out as a result of their parenting. Or ineffective child management, which is basically a nice way of saying you're a bad parent. So ineffective child management is they just don't know how to control their child, they don't discipline their child, they kind of let their child run loose, basically things like that. Diagnosis, this is just kind of something that parents tend to say, is that they'll be bringing in their child to a behavior specialist and, just kind of at the end of their rope be like, my child is 5, 6, 7 years old, but it seems like they never came out of the terrible twos. They just kind of have that same, like, you have children or toddlers, how they, like, go through the stage where they're just, like, everything is no, saying no to everything. So it seems like they just kind of continued in that through their childhood. Again, treatment is just going to be dealing with the symptoms and trying to help their behaviors. So you'll notice that risperidone is here again, same as autism, because these are kind of treating kind of similar outbursts, kind of like the irritability, the acting out, the lashing out. So risperidone is used to stabilize mood, both in ODD and in autism as well. Family therapy is also useful to kind of figure out like what's going on. Is this something that the parents can work on, or is it just purely something going on with the child? All right, then we have various different tic disorders. Tourette's is the one we're going to be talking about. Some of you probably have heard of Tourette's before. Tourette's is the disease where you have these uncontrollable little like movements, whether it be of your head. The head is a very common one where kind of like, it's either like a facial grimace or like a twitching of the head to the side. So that's a motor tic, is anything that involves like an involuntary twitch. And then vocal tics are involuntary outbursts. So it could be someone like saying a word repeatedly or making different sounds, but they're uncontrollable and they're involuntary and they just happen. Etiology, again, most of these are going to be unknown. They find that there tends to be a higher incidence in men. In order to be diagnosed with Tourette's, you have to have both motor and vocal tics. So both of those need to be present, and it needs to be bad enough or frequent enough that it is inhibiting your work environment and socialization. So, having a motor and vocal tic like once a month isn't going to qualify as Tourette's. But typically people with Tourette's have these motor and vocal tics multiple times a day, or they just, these outbursts can be very distracting, like if they're in a classroom environment or if they're at work. Their peers can make fun of them or not have them get along. Especially kids in school have a hard time fitting in with this sort of thing. Treatment for this, these are going to help kind of calm down the part of the brain that are causing these involuntary reactions. So antipsychotics, haloperidol, fluoxetine is going to be to help calm down those repetitive behaviors. And then clonazepam, all the things that end in PAM, like clonazepam, Ativam, what else? Clonazepam, lorazepam, all those things that end in AM like that are benzodiazepines, which you'll see on the drug sheet that I hand out to you guys in a little bit. These are used for calming down. So a lot of people use these. You've probably heard of Ativan and Xanax. That's the same category, kind of like to calm you down. All right, now we're under dementia. Alzheimer's is a type of dementia. Dementia just means like decrease in cognitive function. So Alzheimer's, typically an older person's illness, progressive failure of recent memory. So people with Alzheimer's tend to have a hard time remembering stuff that's happened in the short term. So short-term memory, they tend to not have as much of an issue with like longer-term memory. So they still remember like, their kids and where they grew up. But as like the stage like progresses, the memory continues to get worse. Challenges with thinking and reasoning and judgment. So these are all kind of like frontal lobe activities, like using critical thinking and judging, like, is this a good thing to do right now? Cognitive is going to go down as well. As you can imagine, as people kind of are self-aware that they're losing, their memory and all this, that they might start developing some depression and anxiety related to, just sadness over their loss of function and anxiety over like what's going to happen to them. And then irritability and combativeness kind of just go along with it. You may have seen, different things, different movies kind of sometimes feature Alzheimer's, but sometimes patients will think that they're, 20 years ago, and they're like, oh, where's my wife? And then people are like, no, your wife died, and then they like get brought back to reality, and they get very violent and irritable because it's like happening all over again for them. So it isn't like they were just reminded, oh, my wife died. It's like they're hearing for the first time that their wife passed away. So that's where the irritability and combativeness gets, because they're just like feeling like their life is kind of spinning out of control because they don't know it's real. Etiologies, again, most of these are going to be unknown. There are some genetic tendencies that they've realized. Remember the chromosomes that we talked about back from chapter 1, part of the chromosomes make up your DNA. On the 21st chromosome, there tends to be some abnormalities on patients with Alzheimer's, which happen to be the same chromosome that people with Down syndrome also have. And they've said that they've noticed that as patients get further along in their Alzheimer's, that a lot of the symptoms of Down syndrome and Alzheimer's kind of tend to overlap, and they think that's why like they tend to have the same chromosome abnormality. So for diagnosis for this one, there actually is physical evidence that you can see. So looking at the brain, there is going to be these things called amyloid plaques, and I think there should be a picture here on the next one, yeah. So there's these things called amyloid plaques that show up on the brain. Atrophy of the brain, atrophy just means shrinking, so the brain matter itself is like shrinks and gets smaller. post-mortem means after they die. So they can't really see all of these things in the brain until after the patient dies. They do an autopsy. They can find these things in the brain. So you kind of can't really diagnose them with it ahead of time, but based off of the behaviors, the diagnosis is pretty certain. But after death, they can be like, oh, yep, they've got, the atrophy of the brain and those amyloid plaques. And I'll just show you a picture of those real quick. So this is a healthy brain on the left and severe Alzheimer's on the right. So you can see that the brain matter has just shrunk a lot. So that's the atrophy. And then these amyloid plaques are those little, reddish brown things that show up in the brain. And here's another picture of that too. So this blue are like the neurons, and those orange blobs would be something showing up as an amyloid plaque there in the brain. Treatment for Alzheimer's, again, this treatment is just going to be to help slow the progression of the disease down. You can't cure Alzheimer's. There's no regaining back of brain function that has already been lost, but you can slow the process down. And cholinesterase inhibitors will help to do that. Donepezil is the most commonly prescribed drug for Alzheimer's, followed by rivastigmine. These are both cholinesterase inhibitors, and this just helps, again, slow down the progression of the disease. All right, now we have vascular dementia. Vascular dementia and Alzheimer's are different because they have different causes. They also have slightly different, manifestations, but there are a lot of overlap because they have to do with changes in memory, judgment, thinking, and so forth. There's also a change of personality with dementia. So you can have a very sweet, old man who's never raised his voice or yelled at anyone in his life, and then suddenly he starts becoming hostile and saying all these curse words and being sexually inappropriate, and their family is like, I just don't understand, he's never been this way before. And it's not truly them, it's just the disease manifesting, and it can be very hard for people to cope with it because it's like they're looking at a family member that doesn't even seem like themselves anymore. So what causes this one is kind of in the title, vascular dementia. So it has something to do with the blood vessels, okay? So what happens here is that chronically over a long period of time, blood flow is being reduced to the brain. So it's like the brain cells are kind of slowly being starved for oxygen. And this happens usually because of blocked arteries. You've got the carotid arteries here. Typically people start getting, they have a bad diet, don't exercise as much, so their arteries start to get clogged up with plaque. Atherosclerosis, arteriosclerosis is the hardening and thickening of the arteries with plaque, which causes the blood flow to be decreased, slowly starving those brain cells to death. Diagnosing is typically these patients will have severe atherosclerosis, history of that. They can do a vascular assessment where they scan the different blood vessels to see how much blockage there is. For treatment, you can give antiplatelet drugs, which is basically to prevent any clots from forming, to improve the blood flow. This is kind of similar to the prevention of stroke, right? With CVA, you want to prevent any clots from going to the brain. So they're trying to improve the blood flow to the brain since that's what's causing the dementia. A surgical option they can do if there's a really, really bad clog and there's just the blood flow is so reduced that it can't be fixed with an antiplatelet drug is something called an endarterectomy. This removes the plaque buildup. So you can see in this picture here on the left, this is an artery that's, the yellow stuff is the plaque or the fat that's lining the inside of the arteries. An endarterectomy will remove that plaque out to restore the blood flow and help that oxygen get back to the brain. Okay, any questions so far about anything of those 4 or 5 diagnoses we've done? No? Okay. If you do, don't hesitate to just raise your hand and ask. Okay, now we're in substance-related disorders. The one we're going to talk about is alcoholism. And again, there's more in the book than there is that we're going over in class, so just skip over the ones in the textbooks that we don't cover in the PowerPoint. So alcoholism. When someone is an alcoholic, there will be certain symptoms, such as decrease in inhibitions. So, people not having the same kind of judgment, is this something appropriate for the situation? Their inhibitions kind of go out the door. Judgment is decreased, so that's why a lot of patients that drink end up in the ER with some kind of injury. Concentration is reduced. There will be chronic dysfunction within family and social dynamics because alcoholism, if someone's constantly under the influence, they're not able to be there for their family, they're not able to do a good job at work, not able to show up, their performance is going to suffer. So that's going to be a big clue, is when they're starting to not be able to cope with daily life and function at normal capacity. The other downside to alcoholism is that alcohol is not good for the body, so there will be negative side effects and symptoms in nearly every other organ system, especially the liver. We know that the liver filters the toxins from the bloodstream, so the liver is going to be the main organ that suffers as a result from alcoholism, but every organ is affected negatively by constant presence of alcohol in the system. Etiology, alcohol, ETOH is the abbreviation for alcohol. It's the based off of scientific compounds. It's like ethanol, something. Don't forget that those abbreviations you'll need to be familiar with. ETOH is one of those. ETOH is a CNS depressant, so it makes the brain kind of not work as well. It's the opposite of those CNS stimulants. So like Adderall and Ritalin are CNS stimulants, so they get the brain to be focusing and thinking better and more clearly, whereas alcohol is the opposite. So it makes you not think as clearly and not be able to focus as well. Alcohol can cause physical and psychological dependence. So it's not just purely an addiction of where I really want it, but your body chemistry adapts and now is dependent upon it. So if someone with an alcohol addiction suddenly stops taking alcohol, it's not like with smoking where you just feel the urge to do it. It's their body literally will go into called withdrawal symptoms, where their body can't function properly without it because they've adjusted to the presence of alcohol. So with alcoholics, they have to kind of slowly wean off of it or be under the supervision of a doctor or different medications to make sure that their body isn't going to have negative effects when they stop taking it. They have also noticed that tends to be some genetic predisposition towards alcoholism. So if someone's parent is an alcoholic, the child's more likely to be an alcoholic. Diagnosis, there are screening questionnaires that exist to kind of gauge how much someone's drinking, why someone's drinking, are they doing it to just relax once a week, or is it they need it to function, to wake up in the morning type of thing. There are also blood tests that can show, the presence of the alcohol effects on the body. So we talk about the liver, for example. I don't know if you remember from previous unit, we talked about the enzyme AST and ALT, which is released by the liver when it's in distress. Does that ring a bell? So that is one that will be high because the liver is in distress from all the alcohol. That doesn't necessarily mean that this person is an alcoholic because their liver is in distress. It could be from something else, but it's a good indicator. There are obviously breathalyzers and things you can also do to prove that someone had alcohol in their system. Treatment is going to be, like I said, since it's focusing on physical and psychological, since that's the root of the addiction. So to treat the psychological aspect of needing to drink, there's the Alcoholics Anonymous program. You've probably all heard of that. They support abstinence. So their whole thing is once an alcoholic, always an alcoholic. It's not safe for someone to just try to start to drink socially after that. They're someone's always at risk for becoming an alcoholic again, so they promote abstinence from all alcohol. Now on the physical side, there's a drug called disulfiram. The brand name is called anti-abuse. Now this drug is really interesting because the patient takes it and it kind of thwarts them from drinking alcohol, because if they do drink alcohol when this drug is in their system, it causes severe nausea and vomiting, which obviously is really uncomfortable and people hate that. I personally hate nausea more than any other symptom. I'd rather be in pain than be nauseous. Nausea for me is the absolute worst. So the patients who really want to get better, they can volunteer and opt to take this drug. They're I don't even want to be tempted. If I'm tempted, then it's going to make me have all this nausea and vomiting, and I don't want that. Sometimes this can be court ordered if a patient like refuses to get treatment, or if they have like DUIs or whatever. A court can order them to go on to sulfurram against their will, so that they cannot continue to drink. All right, now we've got schizophrenia. Schizophrenia is a kind of a big chunk in your book. There's more information on that one than any of the other ones. But with schizophrenia, there's something called positive and negative symptoms. So positive symptoms, it doesn't mean that they're a good thing. That's not what positive means. Positive just means the presence of, okay? And then negative means the lack of, not good and bad. They're all bad. So positive symptoms would be, for example, like a hallucination, like the presence of a hallucination. Whereas negative side effects or negative symptoms would be the loss of something. So like the loss of being able to communicate, for example, so like lack of speech. Does that make sense? Okay, so with schizophrenia, these different positive and negative symptoms are going to affect relationships at home, with your family, work. They're going to affect your thinking, perception, beliefs, and self-care. So a lot of times people with schizophrenia, they have, interesting beliefs about the world and about themselves that are contrary to reality. So a common one is that they think that an alien is controlling their brain. It's like, I'm doing clinicals right now, clinical instructors with nursing students at Parkridge Valley. You guys have heard of Parkridge Valley? It's one of the mental health institutions in Chattanooga. And getting to talk to some of these patients, and a frequent one is that they, have heard of paranoid schizophrenic. Is that a term you guys have heard of before? So paranoia is one of these false beliefs that's common in schizophrenia. So that patients believe that they're being persecuted by some group or some power, whether it be the aliens or it be like a secret mafia movement that's after them, and it's a very common delusion of paranoia. Self-care tends to go out the window as well, so not, taking care of themselves physically, showering, brushing their hair, that sort of thing. Again, no one really knows exactly why this happens. There does seem to be a genetic cause, and it's also more common in men. Diagnosis for this, they can do images of brain activity to kind of give an idea of what the brain is doing. There are some other psychological tests that can kind of give an insight to how this person's brain is working. You may have heard of the ink blot test or the Rorschach test. It's the little, this thing right here where they have the ink blot and kind of ask, like, what does this mean to you, or what do you see? A normal person would be like, it looks like a bat or a butterfly or something. Whereas someone with schizophrenia might, see something completely out there, or like this, I don't even know, but like some kind of indicator of what's going on in their brain as they explain what they're seeing. So again, it's not like 100% diagnostic tool, but it does help to kind of see what's going on in these patients' brains. Treatment for schizophrenia, antipsychotics are the first line therapy. This is going to help with their symptoms. There is an injectable option. Instead of like just taking by mouth medications, they can receive a shot of antipsychotics. This tends to help with compliance because you only have to take it once a month. So they just come into the doctor's office, they take a shot, the drug lasts for a month, and they come back. Whereas a lot of people have a hard time taking medication every single day. Sometimes they forget, or especially with psych patients, they don't have the same like autonomy to be able to make sure that they're taking their drugs appropriately. So if someone doesn't have a good caretaker or a good support system to ensure that they're taking their medication, the injectable option might be a better choice. Serious side effects of antipsychotics include something called tardive dyskinesia. This is a serious side effect to look out for. Tardive dyskinesia basically is these involuntary movements that are uncontrollable, kind of like a tic disorder, like Tourette's. But these are the common ones that tend to happen. So sticking the tongue out repeatedly, smacking the lips, making facial grimacings, blinking. So most of them have to do with the face. And then writhing movements can be the whole body, just kind of like this irresistible urge to move, kind of like restless leg syndrome in a way. But if someone starts developing this from taking the meds, they need to be stopped, because if prolonged, this can become permanent. All right, here's some other schizophrenia terms that are in the book, just to make sure you know those as you're reading through. Any questions about schizophrenia? All right, so now we're in mood disorders. Mood disorders, the first one we're going to talk about is bipolar. Bipolar disorder is defined by rapid mood swings between manic and depressive states. And different patients have different lengths of time that they stay in each state. So a manic episode might last a few days, it might even last a few weeks. During a clinical rotation that I'm in currently right now with the students, we were talking to this one man who had been in a manic episode for like 3 weeks straight. And I don't know how he's still functioning, because during manic episodes, it's very difficult for them to sleep at all. So he's talking about how he hasn't slept in like 5 days, and he's just revved up and like going. It's when someone's in a manic episode, it's as if they had, taken 7 shots of espresso, and they're just going, can't stop. So they have like this excess energy, can't sleep. They suddenly want to go like take on all these projects. I have a friend who has bipolar, and I can always kind of tell, because she's always like, I want to start going to school for this. I want to like get my own business. I want to invest in real estate. Like all these like grandiose projects. It's like, whoa, calm down, pick maybe one. And then when it goes back to like the depressive swing, all of those motivations and ideas are like gone. So you're like, oh, I'm just getting through the day. I'm just trying to wake up, So, the other thing is when people are in manic episodes as well, they tend to not have the greatest judgment. So one symptom that is common, especially with women in manic episodes, is excessive spending and shopping. So like, they'll rack up, a huge credit card bill during a manic episode. They just went to the store and bought, thousands of dollars worth of merchandise, which can be, a big problem in straining marital relationships, obviously. On the other hand, depressive episodes is the complete opposite. So very little energy, little desire to do anything, sleeping more than usual instead of sleeping not at all, feeling a lot of guilt and low self-esteem, don't want to talk to anyone, and sometimes suicidal ideation. Again, no clear cause as to why this happens. There does appear to be an imbalance of neurotransmitters in the brain. You've probably heard of dopamine, serotonin, those happy hormones as they get called. So there tends to be either an imbalance, or like one is too high or one's too low, and that tends to cause the swings. Sometimes just having a traumatic past can be enough to give someone a bipolar disorder as a coping kind of mechanism. Diagnostic criteria is going to be just based off the DSM-5, again, looking through the book and seeing if they hit the criteria for these diagnoses. One thing that will want to be ruled out is hypo or hyperthyroid. So if a patient comes in, with really depressed symptoms, they're saying, I'm really tired all the time, I don't have energy to do anything. The first thing a doctor might think is, well, let's check their thyroid hormones, right? Because remember, hypothyroid has to do with their metabolism. So people with hypothyroid tend to be really tired, lack of energy. So this is like one of those things like, okay, are they depressed or are they having a thyroid disorder? Same thing with hyperthyroid. So hyperthyroid, people are revved up, they're like bouncing off the walls, they're ready to go, and that can look a lot like manic episodes, right? So that's one of the things you want to rule out, is if it's a mood disorder or if it's an endocrine disorder that's happening. Does that make sense? All right, for treatment, when they're in a manic episode, lithium is going to be the drug of choice. This is going to help stabilize them, bring them back down a little bit. When they're in a depressive episode, so antidepressants by themselves are going to be used with caution, because antidepressants, they work by giving you, to make you less depressed, right? But in bipolar disorder, giving them an antidepressant by itself is likely to trigger a manic episode. So giving antidepressants with anticonvulsants is going to help prevent that, to kind of stabilize it a little bit better. All right, and here's just a little picture, bipolar disorder, what it looks like on the left for mania and what it looks like on the right for depression. All right, the other mood disorder is just major depressive disorder. This is just pure depression with no manic episodes. So just feeling depressed for chronic periods of time. Symptoms are going to look like the same symptoms for bipolar on the depressive side. So hopelessness, loss of interest, low self-esteem, sleep disturbances, fatigue, loss of pleasure in things that you used to enjoy doing, and suicidal thoughts. There tends to be a familial tendency with depression, so it tends to run in families. Another thing that can cause major depressive disorder is alcoholism. So patients that tend to be alcoholics also tend to struggle with depression, and also having a chronic illness. So people with disabilities or, chronic pain, or they're in a wheelchair, or they're struggling with cancer or something like that, that can lead to constant depression. In order to be diagnosed with major depressive disorder, they have to have at least have this experience for at least 2 weeks, and having 4 or more symptoms. Sorry, that's supposed to say symptoms, not symptoms. My spell check failed me. Okay, treatment. Antidepressants by themselves are fine for patients with major depressive disorder because there's no risk of them triggering a manic episode. So antidepressants, there are different kinds of antidepressants, which we'll talk about a little bit in the psych drugs. SSRIs are the first-line treatment. These tend to be first-line treatment for most things. So the SSRIs, you don't really need to know what this means exactly, but just if you were to see selective serotonin reuptake inhibitors, that's what SSRI stands for. And basically what it's happening is that they're just increasing the amount of serotonin in the brain. Serotonin is one of the happy hormones. So they're just allowing the brain to have more serotonin available. All right, anxiety disorders. Generalized anxiety or panic disorder. Basically, anxiety is a normal biological response to stress. However, in patients with an anxiety disorder, isn't that they feel anxiety, it's that they feel anxiety in an disproportionate amount to what's happening, right? So they can have a very low grade source of stress in their life, but reacting with like an amount of anxiety that's not proportional. Does that make sense? So it's normal for everyone to feel anxiety at some times, but it's when you have this crippling anxiety that's kind of constant and chronic and doesn't go away, and prevents you from having like a normal life, is when it becomes a problem. And you've probably heard of, things people don't leave their house because they're afraid of going outside and meeting people. That's like an extreme case of anxiety. People have some super anxiety about germs, wash their hands and wear masks everywhere because they're just constantly terrified of getting sick. There can be some visible behaviors, like anxiousness can lead to chronic nail biting is one of the symptoms that's common with people that have anxiety. Constant checking. So like, for example, constantly checking the front door when you go to sleep to make sure it's locked, but not just checking once, checking it like 10 times before you go to bed. And it's like, you checked it once, you don't need to check it again, but it's like every time they check it, it relieves the anxiety for a little bit, and that's why they do it. So it's like every time they're reassured momentarily, they get that like feel good, like, okay, I'm safe. And so they just keep doing it over and over again. Or people that constantly check the stove to make sure it's off and it's not on so their house doesn't burn down. Panic attacks are also something that may happen with people with generalized anxiety. Etiology, this can be triggered by people that have had like severe stress in their lives. Like they've went through a really traumatic event, and so now they just have like their body hasn't come down from that. They're just constantly anxious. Or some people just have chronic anxiety from like little to no stress in their lives at all. And it's not really clear as to why it happens to some and not others. There is diagnostic criteria that is diagnostic for it in the DSM-5, but you guys don't need to know those criteria. Just know that that's how it's diagnosed. Treatment for anxiety disorders is going to be meds and therapy to kind of work through like, hey, like why is this stressing you out? Or like, hey, let's think about these fears. Are they realistic? That sort of thing. Relaxation techniques. So like hypnosis is something that some people say that works for them, or massage or exercise to kind of like help with anxiety. SSRIs, again, are first-line therapy. These are the antidepressants, but they're not just used in depression, they're also used for anxiety as well, because it increases those happy hormones to help prevent some of that fear. And then benzodiazepines. These are the calm down drugs. So again, you've probably heard of Xanax or Ativan, used to calm people down. These are very addictive, and so they're given out for only short-term use. If someone's having like a very like an acute anxiety attack, like a panic attack where they need something to calm them down, but this isn't something to take every day. Something to take every day would be like the SSRIs as like a maintenance therapy. But the benzos, there's a big risk for dependence upon them and addiction to them, so those are not given out as to use as a daily basis. Okay, any questions about this so far? All right, and our next anxiety disorder is OCD, obsessive compulsive disorder. So symptoms of this is twofold. There's uncontrollable urges and compulsions, so obsessions and compulsions. So the presence of persistent and unwanted thoughts. So it's like these are kind of like these intrusive thoughts that come into your mind. Those are the obsessions, and then the uncontrollable urges to carry out certain actions. That's the compulsions. We typically see this, like people say, "Oh, I'm OCD," and they mean like they're perfectionists. They have to have things be a certain way. That's kind of like taking it away from a little bit what it means. Like it's kind of just become like a thing people say in the street, like, "Oh, I have OCD," but like really OCD is like they have these actual uncontrollable urges that they actually can't control. Whereas most people who say, "Oh, I'm just OCD," they actually can control it. They just like are just using it lightly, if that makes sense. So it's kind of like where with restless leg syndrome or Tourette's, where it actually is uncontrollable and you can't actually stop. Etiology, again, it could be caused by severe stress. It could be related to dysfunction with the frontal lobe of the brain, or no one's really sure, they don't really know. Psych is kind of the last kind of mystery in medicine of like, we don't really sure like why a lot of this happens. Like, whereas now we know a lot more about other things like cancer and hypertension, like, oh, we know why those happen, but psych is kind of like the last frontier of mystery. We just don't really know. Again, diagnostic is going to be based off the DSM-5, and then treatment is going to be, again, meds and therapy, so relaxation techniques to help calm you down, hypnosis, relaxation, exercises, SSRIs, again, so these are, again, used for depression, anxiety, and now OCD as well, and benzodiazepines as well to kind of calm down. All right, our last one of the anxiety disorders is post-traumatic stress. Now this one is, what's the difference between post-traumatic stress disorder and generalized anxiety disorder is that generalized anxiety tends to just happen for an unknown reason, whereas post-traumatic stress disorder is tied to a specific stressful event that happened. Does that make sense? So like people with generalized anxiety didn't necessarily have a traumatic thing that happened to them in their life. They might have just be anxious without cause. With post-traumatic stress disorder, they either went through something horrific like a war or sexual violence, or even something like a natural disaster, hurricane, tornado. Maybe they lost family members. When someone has PTSD, they actively try to avoid remembering the event. So they definitely are very avoidant of talking about it. They don't want to think about it. When they do run into a trigger that reminds them of it, they tend to react very violently. We typically think of like war veterans who like lash out when they have a memory. Those are called flashbacks, where like they're reliving it over again. So it's like they're in their mind as if it's, and replaying it as if it's happening all over again. They could react with yelling, violence, irritability, because they're just trying desperately to avoid remembering what happened. Diagnostics is just seeing that people have these distressing recollections of the event and these intrusive symptoms like the dreams and the flashbacks. To treat this, counseling is going to be a big one to kind of help them work through it. The more that you avoid something and try to put it under the rug, the stronger its control is going to be over you. You kind of have to face it and come to terms with it and kind of process it and have closure with it for it to not have this effect on you. So counseling is going to be a big one. And then medications to help with the process along the way. Again, SSRIs and benzodiazepines are going to help. There's also animal and pet therapy. So you've seen like these little therapy dogs that they bring to like prisons sometimes. It helps they found that animal and pet therapy is really calming for people. All right, here's just some, some visual symptoms of what PTSD might be. So the intrusive thoughts, avoiding talking about it, just heightened arousal. They have a hard time falling asleep because they're just worked up. All right, now we're in somatoform disorders. The word somatoform is about having to do with something with the body. So everything we've talked about so far has just been like in the mind, whereas somatoform disorders is like linking the mind and the body together. So for example, hypochondriasis, you might have heard someone say, oh, I'm a hypochondriac. It's like, oh, basically a hypochondriac is someone who thinks they're always sick or always has something, right? So these people are like terrified with the idea that they have a disease. They're like convinced that they have, heart failure or cancer or something, because they probably are on WebMD looking up their symptoms and think they have, a month left to live, but they're like convinced that this is true. Even though they've gone to the doctor, gotten checked, gotten tests to prove that they're fine, nothing's wrong with them, they still like believe 100% that they have this thing. No one really knows why this happens. And it's also difficult to diagnose because a lot of the times the patients will hop from doctor to doctor because they're like, oh, well, this doctor didn't believe me. I'm going to go find a doctor that does believe me. So they're convinced that the doctor's the problem, not them. They're like, oh, the doctor just blew me off and didn't take me seriously. So they just keep hopping from doctor to doctor. So it's difficult to actually like establish whether or not someone has something or not. And it's hard for them to like build up like years worth of like, oh, this person like frequently comes in with complaints about something and it's not ever true. So it's kind of hard for doctors to realize if someone is a hypochondriac or not. For this, psychotherapy is really the only treatment, kind of getting people to kind of like talk about why they feel this fear, like why are they convinced, like why do they not think that the doctors believe them, kind of just working through their feelings on it is the really only treatment. Another type of somatoform disorder is something called factitious disorder. It used to be called Munchausen's. Has anybody ever heard of Munchausen's before? Yeah. I still call it Munchausen's. In my brain, it's just always going to be Munchausen's. I guess they call it factitious because it means these people are basically faking an illness. So the difference between this one and the previous one is that hypochondriacs like really 100% believe they have this disease, whereas factitious disorder, they don't believe they have it, but they just want to get attention. So they're trying to convince other people that they have this disorder so they can get special attention. For whatever reason, maybe they didn't get enough attention as a child, or their parents, didn't love them, or they were ignored growing up. They feel like maybe they started getting attention when they got a cold. Now their parents suddenly like paid attention to them. Does that make sense? So it's like they started realizing that like people only care about me and give me attention when I'm sick. So they start developing like fake symptoms, fake illnesses, even going so far as to like actually make them sick on purpose by injecting poisons or taking medicines to make them sick, or exposing themselves to, old food to get food poisoning or whatever, because they want to get some type of attention that they feel like they need. And then there's also, they used to call Munchausen's by proxy, but now they call it factitious disorder inflicted upon another, which is way more wordy to me. And I'm like, I don't know why they changed it, but this is where the person doesn't make themselves sick, but they're inflicting it upon someone else. So usually like a mom will take like their preschooler and be like, oh, they're sick, and take them to the doctor. So people will have pity on them that they have a sick child. Does that make sense? So it's like they make their kids sick. There's been stuff in the news about, they found out that like the mom has been keeping their their child sick for years, or giving them poisoned Jello or whatever it is. And so obviously this is a form of child abuse, and so the efforts to try and take the child away is difficult because, again, just like the previous disorder, they tend to hop from doctor to doctor as soon as the doctors become aware that something's going on. They're like, okay, this isn't real, something's not lining up. The lab tests are, the patient comes in with all these symptoms, but like the lab tests are like inconsistent with what they're saying. So like something's going on, it starts to look fishy, and then just as soon as things are starting to look fishy, they switch doctors and start the process all over again to get attention and not get caught. So it's really sad when it's inflicted upon a child, because this person's need for attention is now hurting someone else, and it can be really sad. Yeah, so there's not really, unfortunately, this one, their treatment is almost impossible because they, first of all, don't want to get treatment to stop doing this. They want to get treatment for their fake illnesses. They don't want to go to therapy and get told that does that make sense? Like, they don't want to go fix the problem. And it's hard to do that because the doctors don't get to stay with them long enough because they just switch doctors. So there's not really any treatment that we know of right now that they can do to kind of fix the problem. All right, sleep disorders. Insomnia. This is kind of another one of those things people just say, oh, I'm an insomniac, I can't sleep. Insomnia is a repetitive, recurrent, chronic thing of difficulty either falling and or staying asleep. So, it takes you hours to fall asleep. Or if you do fall asleep, you constantly wake up and can't stay asleep. So it's dysregulation of your REM sleep. Waking up always feeling groggy, never feeling refreshed, feeling tense and irritable just from chronic lack of good rest. Etiology, there could be 5 million different things causing insomnia, so just trying to figure out what it is. I listed a few of them on here. So shift work, people that work night shifts tend to have a harder time falling asleep because it's during the day that they have to sleep. Taking substances, so alcohol, smoking, and caffeine, all can disrupt sleep. Extreme anxiety or stress, people that travel a lot for work, so like pilots who have to constantly change time zones or travel, like their sleep is constantly getting messed up. Environment, so like if their room is too hot or too cold, or if they're living in an apartment and their upstairs neighbors are like walking around with cinder blocks, on their shoes, like they're having a hard time sleeping, or a barking dog. One of our neighbors has a dog that barks all night long, and it makes me crazy sometimes. RLS is another thing that can cause insomnia, like that feeling in the legs that just prevents you from sleeping. Insomnia tends to be more common in women, which is honestly no surprise, because how many of you guys know that men fall asleep within 5 seconds of closing their eyes? I swear. Whereas it takes me at least an hour to fall asleep, just because I have 30 tabs open in my brain, just constantly thinking about everything. Diagnosis, these periods need to be lasting longer than a month. So it's not like you just had one bad night of sleep and you're like, oh, I have insomnia. This has to be every night, dealing with this for a month straight and nothing's working. Everyone has periods of sleep being disrupted. Right now, my sleep is being disrupted because I have a baby and she needs to eat and she cries all night, but that doesn't mean I have insomnia, right? It means there's a specific cause. Does that make sense? That's the reason. If that reason were taken away, I would sleep fine. So it has to last longer than a month and interfere with life. They can do sleep studies where they hook up monitors to your brain and have you sleep in a clinical setting to watch your brain waves and see your REM sleep. So they can do that as well. Treatment is just to find out what's causing it and remove the cause. Trying to stick to a regular routine. So, going to bed at the same time every night, trying not to be on your screens right before bed. You can take melatonin to kind of help. They try to have you figure that out first before it's just going straight to medications. The medications that help with sleep are benzodiazepines, the calm down drugs, Xanax and Ativan, and then something called hypnotics. Hypnotics, I don't know why they're called hypnotics. It has nothing to do with hypnosis. I guess when people hypnotize you, they say you are getting sleepy. So I guess that's where they got that from. But they help you go to sleep. So you probably heard of anybody heard of Ambien or Lunesta? You see the commercials that talk about for helping go to sleep. Those are examples of hypnotics. Let's see. Let's do a couple more slides, then we can take a break here. All right, narcolepsy is another sleep disorder. This one is irresistible daytime sleep episodes. So these people have an uncontrollable, irresistible urge to just suddenly fall asleep during the day. And it's not under their voluntary control. They are just sitting at their desk and all of a sudden they're out. Tends to happen more frequently during monotonous activity. So if you're sitting in class or if you're driving a car, for example, I tend to get really sleepy when I'm driving and it's a problem. So I don't really like driving. My husband jokes and says I have car-calepsy, he thinks he's funny. But basically, people with narcolepsy, they have a hard time at work or in school. So there are like certain, if a student has this, they can have certain like arrangements made with like a teacher to help give them extra breaks or whatever, so they don't have this problem in class. Etiology, no one really knows, some kind of genetic abnormality with their REM sleep. For diagnosis, one thing you would want to rule out is absent seizures. So remember we talked about in the neuro chapter, absent seizures looks like you just kind of like zone out for a little bit. You don't have any like, you're not like you're shaking on the ground like the normal, like when we think of a seizure, you just kind of like zone out and kind of, you just go kind of absent-minded. So that would be a thing that we want to rule out, that you're not having that instead of narcolepsy. Sleep apnea is another one. Sleep apnea isn't really a psych condition. It's just you have an obstruction in your throat that makes it difficult to breathe when you're laying down. So it constantly wakes you up all night long to get oxygen. As you like, especially happens in men that have like big necks. Their tongue just tends to like close off their airway, so they're constantly waking up over and over and over again all night long, which means their sleep is really terrible, and so they're constantly tired, and so they might fall asleep during the day, right? So it doesn't necessarily have narcolepsy, it means they have sleep apnea. Does that make sense? So trying to figure out, is this truly narcolepsy, or is this being caused by, is this actually a seizure, or is this due to like you're just not sleeping well at night? So those are some things to rule out. Treatment, I mean, really taking therapeutic naps during the day to kind of prevent you falling asleep at inopportune times. And then stimulant drugs, kind of the same thing that you take for ADHD, the stimulants to kind of keep you awake. Methylphenidate is an example, helps improve wakefulness. Basically, they're doing the same thing as like coffee, essentially. Actually, we're just going to go ahead and finish because we have just like 3 slides left. All right. Towards the end here, personality disorders. There's 3 different clusters. There's cluster A, cluster B, and cluster C of personality disorders. Cluster A involves different disorders that include behavior that appears odd or eccentric. So the first one is paranoid personality. Person with paranoid personality, they're just very distrustful, very suspicious of others. They think that everyone's out to get them. They're like, convinced the government is like spying on them. They're like conscious of everything they do because they think they're being watched. They don't believe family members. They think they're just like lying to them. They misinterpret people's actions. So it's like something very, innocent could happen between this person's like, oh, they, I don't even know. Like they take an innocent action and turn it into something less suspicious. Be like, oh, why did she give me her piece of candy? Like, is it poisoned? Like, it's just, they turn everything into something suspicious. Number 2, a schizoid personality. These people are just the kind of like loners. They don't interact with people. They hang to themselves. It's not really clear if they don't even experience emotions, but they like don't show them at all. Like they don't have any like facial expressions of like emotions at all. They just kind of very flat. And then you have schizotypal personality. Similar to schizoid in the sense that they're loners and don't have very much emotions, but they also have on top of that like very superstitious or magical thinking. So they believe in like, I don't know, like very superstitious things like magic is real, the magic is controlling them, the aliens are here, they have an alien living in their brain type of thing. So that's an additional add-on to the schizoid. Then you have cluster B. These fall into the category of behavior that appears dramatic, emotional, or erratic. So the first one is antisocial personality disorder. This is the typical one we think of like kind of like when we think of like a serial killer. I hate to say that, but like, the people that are they have no regard for human life. They have no empathy at all. They're kind of sadistic, they violate others, they are aggressive, they're manipulative, they don't have any remorse for things. So like the typical, like, you think of like, a psychotic killer type of thing. That's the antisocial personality disorder. Then you have borderline personality disorder. This one Okay, so has anyone ever seen the show on Netflix, Crazy Ex-Girlfriend? You've seen it? I love that show. I'm sad that I think it's gone off Netflix now. But that show is based off of this girl who has borderline personality disorder. But it's kind of like her journey of discovering that's her diagnosis. And it's funny, but it's also self-reflective to make you think about like why you're doing certain actions. So it's very well done, but it kind of just brings awareness to this personality disorder. Basically, the whole thing about her is that she has this crazy fear of rejection and abandonment. Hence the title of the show being Crazy Ex-Girlfriend. And she's like constantly trying to like, get with her ex and all this stuff. But anyways, it just highlights the fact that like the behaviors that they have is directly related to this fear of rejection and abandonment. It's like if they didn't have this like intrinsic fear inside of them, they wouldn't be having these behaviors. So like the key to this is to try and heal that sense in them that's like so afraid of being abandoned that those reactive behaviors won't happen, if that makes sense. And it's the reactive behaviors that they do, like the manipulation, the lying, the sarcasm, to try and like manipulate situations to like keep people in your life, that tend to push people away. So it has like the negative effect that's desired. Does that make sense? So this tends to happen with patients that like maybe had parents that like, rejected them or abandoned them or like threw them out of the house, or like so they're constantly afraid of like people they love rejecting them. Histrionic personality disorder, these people tend to be extremely dramatic and theatrical. So like, you think of like a stereotypical, like in the movies, like teenage girl that's like super dramatic, but like insert that into like a grown adult. Like they never grew out of that. So they're extremely dramatic. They constantly need to be the center of attention. They're very immature. They need constant praise and affirmation from their peers. So it's like the stereotype, like teenage girl in the movies, but like as a full-grown adult. They just never grew out of that. And then narcissistic personality disorder. This one is where they're like absorbed with themselves. They are obsessed with themselves. They think that all they really care about is themselves and what they need. And they're willing to manipulate and gaslight others to get what they want. They react very negatively to any type of criticism because they think they're the greatest thing ever. They have this sense of self-importance, and they think everyone else is beneath them. They tend to exploit others, manipulate them for their own needs. This tend to be more common in men, and the histrionic tends to be more common in women. And then lastly, we've got cluster C. Cluster C is behavior that is anxious or fearful. So the first one, avoidant personality. This one is like the stereotypical like teenager with very low self-esteem that's like constantly afraid of like social situations because they're afraid of people making fun of them or laughing at them. They're afraid of not fitting in. They think themselves inferior. They think that they're unappealing. They have low self-esteem, that whole thing. So they don't like to engage with people at all. They avoid all types of social interaction because of that. And then dependent personality. These people have like an excessive dependence upon other people to make decisions for them. So it's like they kind of stay in a childlike mindset where they like don't want to take on adult responsibilities. They just like anything that's like hard, they want someone else to do for them. So it's like they constantly need someone to mom them, if that makes sense. They look for like a figure that will do their adulting for them. They're very passive. They just go along with what other people want because they just want someone to be there all the time to rely on and do the hard things, to make decisions. And then lastly, you have the obsessive compulsive type disorder. This one is extreme preoccupation with orderliness and perfection. So this is similar, I don't know why there's a huge distinction, but it's similar to the obsessive compulsive disorder. But like with the obsessive compulsive disorder, they have like these uncontrollable compulsions to do things, whereas this one is just about perfection and orderliness. So it's like, people go around the house and like constantly readjust their figurines on the table, or like if someone moves it slightly, they like put it back, or like everything has to be perfect, like everything in the house has to be like cleaned all the time. So it's similar but different, even though it has like the same obsessive compulsive in the name. I don't know why they picked that. They should have picked a different name. They didn't ask me. Again, they're so obsessed with details that they might not ever finish tasks. So it's like they're working on a project and they get like so obsessed with every detail being perfect that it's like impossible to actually finish and complete. So, and that is it for the mental health stuff. Are there any questions right off the bat before we go on break? No? All right, let's meet back at, it's 10, 15, 20. Take 15 minutes. So 10:25, come back. Sound good? All right.
In the neuro chapter where it talks about like concussion, we don't have to worry about that for the exam.
Just whatever's on the PowerPoints. Yeah. There's just a lot of stuff in the books that I just took out because it's just not necessary. I figured things like concussion, you probably all heard of that before, so. All right, how can I? Hot in here? I can't keep up. Like it's cold, it's hot. Like I don't know what to wear anymore.
I started coming with some short sleeves. Like, I don't know. I was too scared to do that.
I wore shorts yesterday, just kind of taking a walk. I was like, this is nice. It was perfect out. It was like 65, the sun shining.
Yeah, it's supposed to go to 70 today.
Yeah. I was like, had a nice sweater picked out, and I was like, I guess I'm not wearing that.
Yeah.
So wear my spring shirt. But my plants all think it's spring, so they're all starting to bloom, and it makes me nervous because I'm like, if we have another freeze, they're all gonna die.
Yeah.
It was all around his teeth, it was socket. In his mouth. I said, "What you doing?" Oh, that is too funny. He pulled his sock off and put it in the refrigerator. He's trying to eat the refrigerator. He was just food in there. Yeah, that's what my sister said. She said he put his food in there. He's trying to make it look good target. He's pretty. I thought, I didn't listen to it. Trying to test the refrigerator. It was too far. He's trying to get in it. He's small. He was trying to look into this in the cab. Don't want to easy. He too big. It's not easy. I try to keep him sitting on the couch looking at TV. That ain't gonna work. I thought that was, this is too funny. I told you he was inside the cabinet. He was sitting inside the cabinet. And I heard something going off. I was allowed to sit in all that too when he said something. All kinds of things. It really lasted long, but. Yeah. That's my best one. He don't like you. He time I get him. I pick him up for the daycare. He was one day here. He in the car. I can hear him putting his shoes on. He threw the shoe and it hit me in the back of my head and I was dry. Stop it. I said, you gonna make me have a record, boy. It's so bad. Oh my goodness, he's so busy. I told him call his mom yesterday. I said, I'm not feeling good. Everybody get him tomorrow. Yeah. I said, cause he is a little much. Look. He blowing out. He a little carrier. Yes. Carry all kind of infections. He busy. This is him sitting on the couch. Look, he can fall. He sure will. He will stand up. I said, Mr. Bill. Mr. Bill. My mama said no. I said, last time you were with my sister, his mama said no. How long was he? I said, he's too much. I said, they got it. Oh, yeah. Yeah. He's a busybody. They don't know I couldn't find him. I didn't tell them because they won't let me keep looking. Oh, funny. That is too funny. think that was basically Thursday night, Friday. Just
All right. I wanted to go over some practice questions about what we just talked about, just to kind of see where we're at, if stuff is making sense. All right, and you can always access these again on the PowerPoint if you want to go back through them again yourself. All right, so which disorder is characterized by the following signs and symptoms? Social impairment, isolation, cognitive impairment, language deficits, repetitive motions that can be self-harming, and aversion to physical contact. Nice, good job. Autism. All right, which disorder is characterized by the following? Avoiding activities that require sustained attention and concentration, inability to sit quietly, displays of impatience, may have impulsivity and hyperactivity. Nice, good job. All right, which class of medications is used to treat ADHD? What class? Stimulants, right? So this is going to stimulate their brain to be able to focus better, right? Because they're inattentive, they can't focus and concentrate, so the stimulants are going to help them concentrate better. All right, what condition is diagnosed by the presence of amyloid plaques in the brain? Alzheimer's, good job. What condition is caused by reduced blood flow to the brain from blocked arteries, which leads to hypoxia of brain cells, leading to cell death? Vascular dementia. What's the purpose of an endarterectomy? Yep, so when they have that plaque buildup that's blocking the blood flow to the brain, they can remove that surgically, removing the plaque from the arterial wall to improve the blood flow. All right, wait. In what way does taking the drug disulfiram discourage an alcoholic from drinking? Yep. So if they consume any alcohol at all while taking this drug, it will induce severe nausea and vomiting, which is extremely unpleasant. All right. Tardive dyskinesia is a side effect of which drug class? Antipsychotics. So specifically with like schizophrenia, antipsychotics are first line treatment for schizophrenia. And then all those different, repetitive movements like the tongue sticking out, the blinking, the facial grimacing can be tardive dyskinesia as a side effect of the drug. Okay, what endocrine disorder should be ruled out in a patient with bipolar? Either hyper or hypothyroid, right? Because they can mimic mania or depression. All right, which drug class is first-line therapy for major depressive disorder? SSRIs, nice job, which is a type of antidepressant. All right, but following signs and symptoms. Person is not ill, but seeks medical care to get special attention. May even go as far as to make fake medical history, make themselves sick, or inflict sickness onto a child instead of the self. Yep, or Munchausen's. It's always going to be Munchausen's to me, but factitious disorder is the new term. All right, what are two possible causes of insomnia? There's a bunch. Working. Which kind of working?
Night shift.
Yeah, so night shift, what else? Coffee.
Smoking,
So,
alcohol.
yeah, lots of different things, shift work, substances, anxiety, travel, environment not being right, restless legs, lots of different things. All right, which personality disorder is this? Concerned with self-love and admiration, reacts with rage to criticism, has an inflated sense of self-importance. Narcissism. Yep. I know it can be tempting sometimes to want to start diagnosing people in your mind that you know. It's like, hey, and if that helps you remember for the test, you can be like, that sounds like Bob, or whatever. Which personality disorder is this? Excessively relying on others to make decisions for them and very passive and goes along with others. Dependent personality disorder. Yep. And that is that for the practice questions. Let's see. I want to go over Let me pass these out real quick. Hold on. All right, so I'm opening up the psych drugs that I put on e-learn, but I also have a copy to hand out to you guys. I like paper copies personally, so. And everyone's all about screens now, but I just don't like I think that should be enough. Let me know if I counted wrong. Everyone got one? All right, so went through the farm book and the disease book, made this chart to kind of streamline the information, cut out the unnecessary stuff to highlight what you need to know. I just kind of want to go over it to kind of so you can see it and have it make sense. All right, so the first drug class, benzodiazepines. These are sedatives, they calm you down. Some of the drug examples, I just picked the most common ones. So diazepam, notice it ends with am, that's Valium. Alprazolam also ends with am, that's Xanax. Lorazepam ends in am, and it's Ativan. There's a bunch more, but I'm not requiring you to know those. They also end with lam or pam, so that's pretty easy to identify even if you've never heard of it before. These treat anxiety disorders, seizures as well, as you probably saw from the neuro chapter. It's just anything that requires being calmed down. You saw that pop up a bunch of times on the PowerPoint. And you've got CNS stimulants. These increase certain neurotransmitters in the brain, which increase alertness, attention, and energy. And these are the ones that end with like amphetamine, so Adderall. This one does not end in that, but methylphenidate is Ritalin. Those are the most common ones picked out for these disorders, and ADHD is the main one, and then narcolepsy as well to help them keep from falling asleep during the day, so it stimulates their brain to stay awake. Then we've got SSRIs, which are technically a class of antidepressants, but they're also used for other things besides just depression. They increase serotonin in the brain. The most common, you probably heard of Prozac or Zoloft, like commercials or just in passing, the most common ones prescribed. These are the first line treatment for depression and also anxiety. I think also in the PowerPoint mentioned post-traumatic stress disorder uses this as well. Then we've got two types of antipsychotics. We've got typical antipsychotics and atypical antipsychotics. They might also call it first gen and second gen instead of typical and atypical. These both are types of antipsychotics, they just work slightly different. So the typical antipsychotics, these tend to work best against positive psychotic symptoms. When we talk about schizophrenia, there's positive and negative. So positive is the presence of something, like a delusion or a hallucination. So these tend to work best with preventing those. And those, the most common ones for this are haloperidol and chlorpromazine, or Haldol or Thorazine. So these are used mostly for schizophrenia and also tend to be used for manic episodes of bipolar. When someone goes, sometimes someone's in a manic episode that lasts a long time, they can develop psychotic symptoms just from like being revved up for so long without sleep, they can start hallucinating. Does that make sense? I don't know if anybody's ever like not slept for so long, they like start to like, their brain just starts getting really foggy and maybe start like going out of it a little bit because they're just so tired. It's like after not sleeping for so long, being in this revved up manic state, they can start developing some psychotic episodes. So in that case, could use these as well. Then atypical antipsychotics, these are kind of a newer version of the drug. That's why they're called the second generation. They tend to treat positive and negative symptoms of psychosis. So not just the hallucinations and delusions, but also like the lack of things that people lost. So like lack of communication, lack of speech, lack of personal care and hygiene. And risperidone is an example, and we saw that one mentioned for autism and ODD as well. It's schizophrenia. Hypnotics, these are the ones that help you sleep. Most common ones, like I mentioned, are Ambien, Lunesta. They're called Zolpidem and esopiclone. These are for insomnia to help you just go to sleep better. Mood stabilizers. So these don't just like increase your mood or like whereas an antidepressant like gives you more happy feelings. This one kind of like makes it balanced out. So this is better for like bipolar because they tend to like have a seesaw, right? So bipolar, you don't want to give them antidepressants by themselves because they'll just trigger a manic episode. Where mood stabilizer help them keep them more stable. Lithium is the most common example of mood stabilizers. And then our last two is cholinesterase inhibitors. So what these are going to do is these are going to inhibit the enzyme acetylcholinesterase. And this should sound familiar to you because we talked about this with myasthenia gravis in neuro and in the immune chapter. So this keeps coming back. So that tells you that it's important and it's not going away. So if there's still questions about how this works, feel free to send me an email. I'm happy to explain it to you in more depth. But basically, again, we have an enzyme in our body called acetylcholinesterase, which erases the neurotransmitter acetylcholine. So the presence of this enzyme reduces the acetylcholine. The cholinesterase inhibitors is a drug that is going to get rid of that enzyme, which is going to indirectly increase your acetylcholine levels because the enzyme is not going to be able to work. So donepezil is like the most common one given for Alzheimer's, as is rivastigmine and pyridostigmine. And then there's a bunch of other ones as well that I didn't put on there because they're just less common, but they also end in stigmine, just like pyridostigmine and rivastigmine. And those treat Alzheimer's. All right, and the last one, the alcohol deterrent, produces nausea and vomiting when alcohol is consumed with it, and that is disulfiram, used in alcoholism. All right, and that is the condensed version of the entire farm chapter and everything I extracted from the disease. So hopefully this is helpful to you, laid out this way, to supplement your studying. Are there any questions or anything that isn't clear about this chart that I made?
So do we still need to read the farm book?
You still need to read the book because there's things in the chapters. I said, remember when you read the book, you just don't have to look at the green medication charts because that gives you way more medications than you need to know.
Do we also have to know the ones in parentheses?
The ones in parentheses is just so you know, because usually you've heard of those. They just kind of give you some reference of what it is. So like, most people probably heard of Xanax, right? They might not have heard of alprazolam. So rather than just be like these long names you've never heard of, it kind of like ties it to something that you know. You probably will see the long version of the name more common in like in doctor's notes. So it's good to be familiar with that. But I put both just because you might see one or the other. But usually you'll see the long name just in charting, just because that's the official name of the drug. So, as you read the farm chapters, a lot of it is going to be repetitive of what the disease book said. So it's not like it's all this brand new information. It's just supplementing. There is some like new stuff in there. That's why it's important to read it. But it's like, so when you cut out all of the green charts, it whittles it down a lot. So it's not like all this brand new information. It's nothing in there that we haven't talked about in the disease book. It should only be a couple pages. Anything else about this chart that is unclear? No? Okay. Hopefully these are helpful to you, laying them out this way. It helps me to kind of just see it all in one spot rather than having to read a book and have it pulled all the pieces out of information by myself.